Hospital. My topic for today is acute limb ischemia, evaluation, decision making, surgical and endovascular management. So, what is acute limb ischemia? So, as per the definition, it is acute ischemia is defined as any sudden decrease in limb perfusion causing a potential threat to the limb viability is a acute limb. So historic rates of amputation and mortality ranges from 10% to 25%. So out of 100 patients, there is a high chance of 10 to 25% patients going for either amputation or a mortality. And broadly, we divide acute limb ischemia into three categories. Cat 1. So most of this patient may need an intervention, or we may get away with a conservative approach. Category 3. Usually they don't merit any revascularization because most of the time the muscles and all are dead. So attempted revascularization can lead to complications like rhabdomyolysis and acute renal failure and associated complications. And category 2 is the most important category, and there comes category 2A and category 2B. So the importance of making a decision is mainly depends on the category 2 patients. So this is one of the toughest challenges encountered by a vascular surgeon, and the preliminary evaluation is basically most of clinical. So once a patient comes to us with the features of acute limb ischemia, so majority of the decisions and clinical evaluation, the major depends upon the clinical evaluation. And a simple diagnostic error can lead to a limb loss and a risk to life. So if we don't able to find that this patient is having an acute limb ischemia component, and if you don't interfere immediately, the patient can end up in a limb loss or he can die. And treatment, multiple options are available, and treatment plans depends upon the comorbidities and the presentation of the patient. So it doesn't mean that all patients coming with a category 2A or category B falls into this management protocol. So always management decision depends upon the how the patient presents and limb ischemia status and associated with the comorbidities of whether the patient is fit for a major procedure or not. So comorbidities are very important in making decision. So we come to etiology and pathology. So what are the causes for acute limb ischemia? It can be an embolism, it can be a thrombosis, it can be a trauma, or it could be an iatrogenic causes. So embolism derives from the Greek word called embolus, means a plug, and usually the source arises from the heart, and it travels to an area where most of the arterial bifurcations where the embolus gets stuck, and it produces limb ischemia distal to that area. And atherosclerotic debris, especially from a very craggy aorta, thoracic or abdominal aorta, so atherosclerotic debris from that major high flow vessels can lead to embolism. And common signs of occlusion, as I already mentioned, common femoral artery bifurcation, popliteal artery trifurcations, brachial bifurcation, profunda brachiorigin. So these are the major sites of embolic occlusions. And sometimes what you call saddle embolism, a large thrombus, large embolus obstructing the aortic bifurcation is called a saddle embolism. Embolism presentation usually catastrophic, usually occurs in otherwise normal artery with not much collateral formation. So a patient who doesn't have any chronic atherosclerotic disease, those who doesn't have any much collateralization. So when this patient presents with a sudden occlusion of the limb arteries, so the clinical manifestations are going to be very catastrophic, because there are no much developed collaterals to supply the distal part, which is distal to the occlusion, and presents with a sensory motor deficit with the white leg. So patients having acute limb ischemia without much collateralization, patient usually presents, sometimes they may have a sensory impairment, sometimes they may have a sensory and motor impairment, and sometimes they present the white leg. And the ischemia worsens with the development of secondary thrombus. So distal to the occlusion, there, because of the stagnation and sluggish flow, there is a high possibility that patient is developing a secondary thrombus. So this is a plum colored thrombus distal to the primary embolus. So that causes more of worsening of the clinical situation of the patient, because that occludes the remaining small collateral vessels distal to that. So coming to the etiology again, cardiac etiology, atrial and ventricular chamber, common causes are atrial fibrillation. So because of the atrial fibrillation, there is a stagnation of blood in the left atrial appendages, and there is a formation of a embolus which is travel to the circulatory system. And it is a very platelet rich thrombus, white surface. And sometimes because of mural thrombus, which patient with a post myocardial infarction, they are prone for mural thrombus formation, which can get dislodged to the circulatory system, produce acute limb ischemia. And some patients with the post myocardial infarction having a aneurysm of the left ventricle, there can again thrombus formation happens, which can be dislodged. And valvular heart disease, prosthetic valves, they are all prone for development of thrombus, and they are again this can get dislodged and produce embolism. Paradoxical embolism, clot from a venous side, because through the patent foramen ovale, clot from the venous side can travel to the left atrium, and from that it can come left ventricle, through that can get into the circulatory system, and it can again produce a acute limb ischemia. Suspected in patient with a arterial ischemia with acute DVT. So patient with having a acute DVT, when the patient presents or shows the symptoms of an arterial ischemia also, then we have to suspect that is there any paradoxical embolism. Endocarditis is common in IV drug abusers, indwelling arterial venous catheter or immunocompromised patients. Again, they are prone for developing a vegetations in the valve, and they can dislodge and produce acute limb ischemia. Cardiac tumor, rarely. Atrial myxoma from the left heart is a benign tumor, and again the tumor particles can produce embolism. Other non-cardiac embolism causes are atheroembolism, extensive atherosclerosis of native large arteries like arch aorta, thoracic aorta. The fragments of the plaque adherent thrombus can embolize and produce acute limb ischemia. Aortic mural thrombus, hypercoagulable condition in the absence of an aortic pathology. So there may not be any aortic pathology, but hypercoagulable state can produce aortic mural thrombi. Plaque rupture, dissection, and hypercoagulability again can produce presence with acute limb ischemia. Atherosclerotic obstruction, progression of a stenotic lesion. So sometimes when we see a acute limb ischemia patient, there is an underlying chronic component also. So there is a progression of the stenotic lesion, and there is a rupture of the plaque, which can lead to acute symptoms due to formation of acute thrombus. And this kind of patient presents with a less severe symptom, because already they have a chronic component in the background. So there are multiple collateralization already happened. So these patients can have a little subacute kind of presentation, and it is not that catastrophic. Hypercoagulable state, thrombocytosis, malignancy, hepatic thrombosis. These patients are having a hypercoagulable state, and they are prone for acute limb ischemia. Vasospasm, primary Raynaud's disease, secondary Raynaud's phenomenon, and these patients are present with the exacerbation of symptoms. There will be some underlying triggering factor which causes the worsening of their symptoms, and patient can produce with the present with acute limb ischemia, and usually most of these patients are managed conservatively with the vasodilators. Aortic dissection is other pathology. Patient can present with acute limb ischemia. And the one symptom patient may be giving is acute sudden onset of chest pain radiating to the back. And the patient may not be having a palpable pulse. So patient giving this history of acute onset of chest pain radiating to back with the lower limb ischemia, we have to, and especially in the background of hypertension, we have to suspect aortic dissection. And sometimes patient can present the bypass graft occlusion. For patient who already had a bypass either for a acute case, underlying pathology, or a chronic disease, and when the graft gets occluded, patient can present with the features of acute limb ischemia. So clinical presentation depends on the size of the artery occluded and collaterals developed beforehand. As I already mentioned, the patient underlying chronic disease will have already developed collateral, so patients may not have a very severe symptoms. But on the other hand, young patient without any underlying pathology, without any chronic under component behind, so this patient presents with a severe symptoms. And the size of the artery, if the patient presents with a occlusion of the iliac artery or common femoral artery, the symptoms will be very severe, that because the major inflow vessels are occluded, the patient's symptoms will be more. And sudden occlusion of a major artery without any collaterals produces acute white leg. Isolated SFA occlusion with a well-established collateral system, patient can present asymptomatically also. Patient may present with some claudication kind of pain, but on evaluation we may see that there is a isolated SFA occlusion, but the patient with the underlying chronic disease, well collateralized system through the profunda is supplying the leg, so patient may not be present with a severe symptom. Acute ischemia, sensory nerve affects first. So the loss of sensation is the earliest symptom which the patient is going to be present. Motor nerve affect the next. So the patient have a muscle weakness, followed by skin, and finally muscles get affected. Muscle tenderness is the end stage sign of limb ischemia. So when a patient comes to the casualty or OPD with the features of acute limb ischemia, and when we evaluate, and if you found that the patient is of severe calf tenderness, so it is most of the time when we do a fasciotomy, and we will see the most of the time the muscles may be dead. And so we have to counsel, I am coming to that. So if this presentation is a severe muscle tenderness is almost conclusive of a end stage signs of limb ischemia. Once ischemia is established, pallor turns into blue because of the capillary vasodilatation, and the pressure over the skin leaves a pallor. In case of advanced ischemia, pressure over the skin leaves no pallor due to the disruption of the blood vessels, and it is an contraindication for a revascularization due to possible renal failure. As I already mentioned, with the category 3 dead limb patient, these are the signs we can elicit, and if you attempt a revascularization, there is a high chance of patient going into a compartment syndrome and renal failure. So again, clinical assessment, evaluation of the limb and patient as a whole is very important, because not only we see the limb, we have to see what is the source of the embolus, what are the comorbidities of the patient, what is the presenting status, and the age of the patient. These are all very important. History, symptoms range from incapacitating pain to sudden onset of claudication. Patient may be walking normally, suddenly patient will experiencing severe excruciating pain over the upper limb or lower limb because of the sudden occlusion of the mainly the bifurcation of the vessels get occluded. So patient presents with a severe onset of pain. And severe ischemia pain with loss of patient presents to the casualty with not only pain, patient will have sensory loss, and patient may have a motor weakness also. Even the patient have a mild ischemia, presents with a mild pain and confusing symptoms. So patient may be coming to the casualty with the features of pain, and we may not be, because of there may be partial occlusion of the vessel. So some circulation will keep the system patent, so that there won't be any sensory and motor symptoms. So it can get, so the clinician can get confused with other causes like musculoskeletal pain or a sciatica. And what about the time? Severe 6 to 8 hours can delay lead to irreversible damage. So initially in my slides I said a minor mistake from the surgeon to pick the acute limb ischemia can lead to irreversible damage, and the patient can lose the limb, and he can sometimes can lead to death. Clinical history, very important to roll out the possible cause and comorbidity. So if the patient gives a history of any coronary event in the past, then we can think that there must be clot might have came from the heart. And other thing, in patient we have to take the history of any underlying cerebrovascular disease, chronic kidney disease, diabetes mellitus. So all this we have to consider when we plan the patient for any definitive management. So the typical physical findings in acute limb ischemia: role of P, so pain, pallor, paresthesia, pulse deficit, paralysis, and perishing with cold. So these are the role of P. So when a patient comes with the pain, paralysis, pulselessness, perishing cold, pallor, and paresthesia, So these are the typical signs we elicit in signs and symptoms we elicit in a patient with acute limb ischemia. So when we examine the patient, the color of the skin, marble white color is indicative of acute total occlusion of the vessels. Slow capillary fill shows a patent distal run of vessels with a minimum flow. So if there is a capillary refill and which is delayed, so that means the patient has got some collateral formation and there is a patents of the distal run of vessels. So there's that minimal flow gives you the delayed capillary refill. Sensation, loss of fine touch and proprioception is the important finding. So these are the initial sensory findings which can elicit is a loss of fine touch and proprioception. Muscle tenderness, especially calf muscle, eliciting a calf muscle tenderness is very important because it is a sign of advanced ischemia. And obviously peripheral pulse, there won't be any pulse palpable distal to the occlusion. It gives an indirect evidence of level of occlusion. So if a patient comes with acute limb ischemia, if we can elicit a femoral pulse and if you are not able to elicit a popliteal pulse, so definitely we can tell that occlusion is distal to the CFA bifurcation. And the same if a patient presents upper limb ischemia, if we cannot elicit a brachial pulse and the patient, if you can try and palpate the axillary, then we can definitely say that this occlusion is between the axillary and brachial. So like that, and sometimes water hammer pulse. So just above the level of occlusion, we can feel for a strong pulse at the site of occlusion. So that's called water hammer pulse. And always it is better to roll out aortic and popliteal aneurysm and atrial fibrillation. So in atrial fibrillation, when you clinically examine the patient, we can have a irregular pulse we can elicit. And in case of aortic aneurysm, when we examine the patient, sometimes we may able to palpate a pulsatile mass in the periabdomen, so we can indirectly give some information it's going to be an aortic aneurysm. And sometimes there will be a pulsatile mass in the popliteal area with a distal limb ischemia, so we can assume that there could be a popliteal aneurysm. And in clinical examination itself, we can use a handheld Doppler, and if we are not, a signal may be present or may be absent also. So if a patient presents limb ischemia and if you are trying to elicit any signal in distal to the occlusion, and if there is a mild signal, then that means there is some flow is there and the limb viability going to be better. And if there is no signal at all, that means it's a complete occlusion distal to that. And in the other investigation we can do in the OPD basis or the casualty setting is a color Doppler. And if the Doppler doesn't shows any flow, that indirectly gives a poor prognostic sign. Waveform can be, and in color Doppler, if we can elicit a color Doppler waveform, if it is a biphasic or monophasic, it can it depends on if there's a very mild occlusion, we can get a biphasic flow. And sometimes in a Doppler, we can elicit that the artery is completely filled and distended with thrombus also. And it is also important to see the venous flow also. When a patient comes with arterial occlusion, it is better to see for the venous flow because absent venous flow is a very poor prognostic sign. And angle pressure of 30 to 50 millimeters and AVP of the 0.3 expected in severe limb ischemia. So if you have the time to measure AVP and all, and if it is less than 0.3, that means it is already in a severe limb ischemia. So classification. So that's about clinical presentation, history, and generally about the etiologies of the acute limb ischemia. Now I'm coming to classification. So etiology, thrombosis, young age and high risk amputation. Embolism is usually seen in older age group, and traumatic can comes in mostly in young age group, but it can be present in both. So it's a Rutherford classification of acute limb ischemia. Stage 1, prognosis is limb viable, not immediately threatened, and there is no sensory or motor weakness. And in Doppler examination, we can get both arterial and venous signals. In category 2A, limb is marginally threatened, salvageable if promptly treated. So we are not supposed to waste any time. We have to take quick decisions in category 2A and 2B. And findings in category 2A, there is a minimal sensory loss, but there is no motor weakness. And Doppler signal, arterial often inaudible. We may or may not get the arterial signal, but venous signal is always audible. And category 2B, limb is immediately threatened, salvageable with immediate revascularization. So in category 2B, we don't have much time to lose. And most of the patient presents with a sensory and motor weakness with a no arterial signal, but venous signal still it is audible. In category 3, limb is reversibly damaged, major tissue loss or permanent nerve damage already occurred. There is profound sensory loss, and there is already muscle, the patient going to present with the paralysis, and there is not going to be any arterial venous signal in color Doppler evaluation. So this is a broadly classification of acute limb ischemia. So it's a patient with the presenting with the acute type 1 class 1 limb ischemia. So class 2 patient with mild motor weakness, and you can see the left side is already patient is presented with the paralysis and foot drop and all. So this is going to be category 3 kind of limb ischemia. So I am coming to few specific conditions and how you manage this patient presents with this specific conditions. So patient with acute limb ischemia, and we on evaluation we found to that is a patient is having aortic occlusion. So usually this patient presents with a paralysis of both lower limb, and modeling changes it can extend above the inguinal ligament. No lower limb peripheral pulse is going to be palpable because it's from bifurcation itself it is occluded, and it can be associated with the renal failure. Sometimes the aortic occlusion, if it is extending above the up to the renal artery origin, so patient can have associated renal failure. Now the etiology can be thrombotic, embolic, or dissection. And a young patient hypertensive with the chest pain and all, we have to suspect aortic dissection. So patient with a saddle embolism at the aortic bifurcation in the left side, and post revascularization, we can see the good runoff across the bifurcation after embolectomy. So next we come to patients with the iliac occlusion. Clinical presentation can mimic aortic occlusion if the bilateral iliacs are occluded, or if the unilateral iliac is occluded, patient presents with the absent pulse on the index side with the modeling changes can extend up to the inguinal ligament. So in this picture we can see the right common iliac artery is occluded and there is no vessel is visible in the angiogram. Distal to that. Patients the femoropopliteal occlusion, this is the most common type. Severity depends upon the patency of the profunda femoral artery. So if the thrombus is sitting at the common femoral artery which is occluding both the profunda and SFA, the patient is going to be present with the severe symptoms with the and if the suppose the thrombus is occluding the SFA from origin or distal to that, if the profunda is flowing, then the patient is going to mild symptoms. So the patency of the profunda is very important in case of femoropopliteal occlusion. Water hammer pulse, because we just above the occlusion we can feel water hammer type of pulse, and usually presents with the all limb ischemia is present with the rules of P, and Doppler evaluation in femoropopliteal occlusion we can see distended artery with acute thrombus. So in this patient, we can see acute thrombotic occlusion of a SFA just after origin with a patent profunda. Next to the popliteal and tibial vessel occlusion. The patient presents with a palpable femoral pulse and absent popliteal pulse. And again, the rule of patient will present with a pain, paralysis, pulseless, paresthesia and all. And always we have to see, is there any popliteal aneurysm? So patient presents with the popliteal and tibial vessel occlusion. We have to see, is there any popliteal aneurysm also? Sometimes we have to rule out a popliteal entrapment or cystic medial necrosis in young patients when they present with the acute limb ischemia from popliteal below onwards, and rarely associated with popliteal aneurysm, popliteal mass. So either we get a pulsatile mass or sometimes we can get a non-pulsatile mass with the acute limb ischemia. So always Doppler and CT will give you a clear picture. So is a patient having acute popliteal thrombotic occlusion with a limb ischemia. So that was in rough in general about the usual conditions underlying with which the patient can present with the limb ischemia. Now we come to investigation. So when this patient comes, what all investigations we have to do? is it necessary to do any investigation also? So when a patient comes, if you see that the patient limb is category 2B, and if they're without any other comorbidities, and if Doppler itself gives you a diagnosis that we can, if we can see either SFA and popliteal is distended with acute thrombus, sometimes we can take a decision and we can operate in saving a time and salvaging the limb. But otherwise, if we have the luxury to have some investigation, then how will you proceed? First and foremost, investigation non-invasive test is a color Doppler, which is always available in vascular surgery OPDs. So in initial evaluation with a color Doppler is going to be a first investigation. So again, in Doppler, will give you the level of occlusion. So and we can see the arteries are distended with thrombus and the distal runoff vessels. If the distal runoff is the distal runoff vessel patent, and other we can see is there any venous flow and is there any minimal flow seen in the distal runoff vessel. So Doppler will give you a roughly idea about the level of occlusion and the distal runoff vessels. The next investigation is CT angiography. I will come in detail regarding all this investigation. So either we can do CT or a transfemoral angiography. If you have a hybrid operation setup, we can proceed. If you don't have the time to do a CT angiography, we can do a on-table transfemoral angiography in case of lower limb ischemia, or we can do upper limb transfemoral angiography of the upper limb also in case of upper limb ischemia. Next, we can go for MR angiography if the patient is having a chronic kidney disease with a high creatinine, not on dialysis patient, we can proceed with MR angiography. And the other routine investigation, CBC, renal function test, INR, and an ABG or VBG will give you roughly about regarding the hemoglobin, creatinine, platelet count, INR value, and ABG and VBG will give you roughly about acidosis and electrolyte imbalance. And a chest X-ray, ECG, and echo. Chest X-ray, sometimes patient presents with an upper limb ischemia, we may have to take a chest X-ray with a neck. We will give you is there any cervical rib. ECG, if you are feeling irregular pulse, and ECG can confirm that the patient may have an atrial fibrillation. Echo, if possible, we can do an echo, and it will give you one finding. It can give you is there any cardiac thrombus, and the second thing is will give you indirect evidence of any ejection fraction. So and about the clinical status of the patient. And the next is the thrombophilia workup. Not all cases need investigation to do diagnose, may need to take for a surgery due to critical nature of ischemia. On-table angiogram can be taken in a hybrid operating room. So color Doppler, as I already mentioned, is non-invasive, easily available, and no time consuming. It's easily reproducible. Artery will be dilated and distended to acute thrombus. Monophasic to no flow can be seen in the distal to the thrombus, and flows in the vein. No flow shows a poor prognostic sign. So you can see there is a acute thrombus in the proximal SFA, which show the artery is dilated and distended with the thrombus. There is a CT angiography is investigation of choice in acute limb ischemia. If we have the liberty to the investigation, we have the time, that means the limb is not that threatened. So CT angiography is very useful, and particularly useful aorta iliac occlusion or iliac occlusion for planning an intervention. So that CT will give you complete picture that what is the level of the occlusion, where is the reformation, what is the status of the distal runoff vessel. So CT will be very important in planning. And the limitations of CT scan is invasive. It's an invasive procedure. It's a contrast material we are using. It's a radiation exposure to the patient, and it needs a expertise for interpretation. And the obviously the contrast material is going to be a renal tox to the transfemoral angiography. Again, is done in hybrid operating room. Brachial approach, in the absence of femoral pulse, we can approach a brachial route. It defines the level of occlusion and nature of occlusion, and is preferred in a planned endovascular approach. So transfemoral angiography is not a routine investigation to diagnose, but actually if we are planning for a we already saw the patient clinically evaluated. Doppler gave you a rough idea about what is the disease and what is the level. So we are taking a angiogram, transfemoral angiogram, when we are planning to proceed with the endovascular approach. So most of the time we do this when we have a plan in mind to proceed with the endovascular. That means either a thrombolysis or angioplasty or stenting. And when MR angiography not used in acute setting because it's a very time consuming and expensive, gadolinium can produce gadolinium induced nephrogenic systemic fibrosis. But still, if you have the time and patient having a raised creatinine level, then we can proceed with MR angiography if needed. And echo not indicated in all cases because it depends on operating surgeon whether the surgeon wants to get an echo preoperatively. And usually rule out septal defect, valvular heart disease, cardiac tumor, and it looks for vegetations, left side atrial and ventricular clot, and it can look for ejection fraction and is there any regional wall motion abnormality. So that was the investigation, how we can proceed with investigations. Then next we come to initial management. All patients with acute limb ischemia, some steps are common for all patients. Immediate interventions. First, we have to anticoagulate the patient because it prevents secondary thrombus formation in the underperfused vessel. So, depending upon the weight of the patient, we do systemic heparinization of the patient. We use unfractioned heparin we use, and the advantages we can reverse with the protamine also. And the bolus is given as per body weight 80 into 100, 80 to 100 unit per kilogram body weight, followed by 18 unit per kilogram as an infusion per hour. And our target APTT is usually 2 to 3 times the normal, and we monitor the APTT 8th hourly. Sometimes LMW low molecular heparin also we can use, but the problem is we cannot use any antidote, and so most of the time we prefer heparin only. Other initial measures of oxygen supplementation because the tissues are already hypoxic. So to improve the skin perfusion and improve the viability of the muscles and skin, we supplement oxygen. And IV fluid, most of these patients are in dehydrated stage. So one thing we have to do is hydrate the patient, improve the urine output, and the other thing is we are going to give a contrast for this patient during the procedure. So IV hydration will improve the renal function, improve the urine output, and prevent renal failure by proper hydration, renoprotective medicines to prevent contrast-induced nephropathy, and proper analgesia. So most of the patients will have severe wincing pain. So proper analgesia, opioid analgesics are preferred to stabilize the patient. So next is the definitive management options. Either it is an anticoagulation alone or should be surgical intervention, endovascular intervention, thrombolysis, or mechanical thrombectomy, or hybrid procedure. So anticoagulation, heparin is prevents the formation of secondary thrombus and prevent progression of the disease. No thrombolytic effect for the heparin, just prevents the formation of a secondary thrombus. It can be a bridging option in unstable patient to prevent a further progression of the disease. Sometimes a patient, when they are presenting, the clinical condition of the patient may be so unstable to take for any simple procedure. So in that time, we can heparinize the patient, prevent further damage, stabilize the patient. Then once the patient is stable, we can take him for a definitive procedure. Heparin infusion improves the outcome after embolectomy. So studies have shown that heparin infusion in the preoperative period improves the outcome after embolectomy. And in class 3 patient, where we are not going to do any even though revascularization, but heparin can be given this patient to prevent further damage, so that until the patient is fit for amputation. So what are the endovascular options available? Mechanical thrombectomy with homemade aspiration embolectomy or commercially available custom built devices. It can produce embolectomy, thrombolysis in unsuccessful cases. Thrombolysis useful in large, medium, and small vessel occlusion. Selection of surgical and endovascular option depends upon the expertise of the surgeon and severity of the ischemia. And how will you select the intervention? Endovascular first, centers which are lot of expertise in doing endovascular options. They can opt for endovascular options first, but the expenses are going to be more. And open technique carries more morbidity and limb loss. So in category 1, manage mostly with anticoagulation. So when a patient having a mild ischemia, if unstable patient, we can proceed with the anticoagulation alone. But intervention, either endovascular or surgical, is advised rarely, and the decision depending upon the location of the occlusion, duration of occlusion, type of occlusion, and the comorbidity and the presence of atherosclerotic component. So if a young patient otherwise fit presents with a acute limb ischemia, it is always better to proceed with either endovascular or a surgical intervention to revascularize the limb, because in the long term the patient that is going to be a better outcome. But in a elderly patient, multiple comorbidities, where the surgical intervention, whether it's endovascular or surgical, is going to be a high risk for the patient. And if we can manage the limb ischemia with anticoagulation, that is going to be the option. In category 2 acute limb ischemia, all category 2 requires some kind of intervention. Because the limb is already threatened, the patient presents with either sensory or motor or combined sensory motor weakness. So intervention is required in category 2 limb ischemia. So what intervention we will do, that depends upon the severity of the ischemia, comorbidities of the patient, and the type of occlusion. Obvious embolus treated by embolectomy most. So in a patient presents with a aortoiliac occlusion because of obvious embolus, and if the patient is fit for a procedure, and if the limbs are marginally threatened or severely threatened, so in that condition we don't have the time to proceed with either a thrombolysis or mechanical thromboaspiration. So better in this kind of patient, it is better to proceed with an embolectomy, because embolectomy ensures the inline flow immediately. So in a patient, surgically fit patient presents with obvious embolic occlusion, so it is always better to proceed with the embolectomy. Alternative approaches are intra-arterial thrombolysis or mechanical thrombectomy. If the patient limb is marginally threatened, and if the clinician can, on evaluation, find that we can have a 24 hours of endovascular kind of management, then we can proceed with the intra-arterial thrombolysis or a mechanical thrombectomy. So that is the decision solely depend upon the ischemia of the limb. If the limb is marginally threatened, we can have 24 hours at least, then we can proceed with the endovascular approach. And then, as I already mentioned, fit patient, surgical option considered first. Unfit comorbid conditions, endovascular option considered first. And in an obvious embolic source, acute category type 2B limb ischemia with a normal pulse on the contralateral side, it suggests embolectomy first, because in this patient there is no underlying chronic component. There are not going to be any collateralization previously. So these kind of patients are prone for a rapid progression of the limb ischemia and limb loss. So it is better to proceed with the embolectomy first. In acute CAT 2A, acute subcritical ischemia, open or endovascular approach can be done. Decision depends upon if the limb ischemia symptoms are more than 2 weeks. Surgical option going to be better, because the thrombus is going to be little bit organized, so it is very difficult to lyse the thrombus. So it is better to proceed with the embolectomy. And if the thrombus is very fresh, less than 2 weeks of old, then if the limb is not that threatened, like in category 2A, we can proceed with the thrombolysis. Acute embolic occlusion of CFA, brachial bifurcation or aortic bifurcation, delay in revascularization can lead to metabolic complications. So in these conditions, so it always depends upon the presentation of the patient, and if there is no other underlying problem, we can do endovascular approach. Or if the patient is already going for a renal failure and features suggestive of muscle death, that it is better to proceed with the embolectomy. Acute critical ischemia CAT 2B needs urgent intervention, and the institution where expertise limited, better to go for a surgical intervention. In expert hands, again, endovascular options like percutaneous thrombectomy, high dose axillary thrombolysis, and pulse spray thrombolysis we can attempt. In spite of having a hybrid operating room and expertise in critical ischemia, open surgery prefer to preserve limb ischemia. So the decision in CAT 2B, it depends on the expertise of the surgeon. If they have the expertise to proceed with the endovascular, again, like a percutaneous thrombectomy in high dose accelerated thrombolysis with a high dose of actylis, again they can try for initially if they have the expertise. So when now I coming to thrombolysis, 75 to 92% success rate is observed in thrombolysis patient when in acute limb ischemia. the usual agent we use a recombinant tissue plasmid activator, that's Altiplase. So you do retrograde contralateral approach usually preferred, and you do a diagnostic angiogram, confirm the lesion and target outflow vessel, and usually we do a guide wire traversal test to see is the soft thrombus. So if we can easily pass the guide wire across the thrombus, then that means it's a fresh soft thrombus. Then the success rate of thrombolysis is going to be high. So then we can proceed with the thrombolysis. And always, when you are planning to go for a thrombolysis, avoid multiple and blind puncture. Always ultrasound guided puncture. Single puncture is advocated, because when we start thrombolysis, the multiple puncture, blind puncture can can lead to pseudoaneurysm formation, hematoma, and complications. And in case of graft thrombosis, direct puncture can be considered if unable to cross the anastomosis. And once the lesion crossed with the wire catheter, advanced and confirmation angiogram taken and exchange to fountain catheter. And the success of thrombolysis depends on few factors. Recent graft occlusion less than 14 days of age. Guide wire traversal test of occluded graft is positive. Graft patency of at least 1 year prior to the thrombotic event. And the presence of a remediable lesion that may be treated. So once we do a thrombolysis and we come across with a stenosis of the anastomosis, then we can do a ballooning of the lesion. So there could be some lesion distal to the occlusion. So these are the some features suggestive success of thrombolysis. And the poor outcome associated are diabetes, current smoking, and prosthetic graft material. So thrombolytic agent, usually we use a recombinant tissue plasminogen activator. Other agents we use streptokinase and urokinase. And the contraindications for a pharmacological thrombolysis are absolute contraindications are active bleeding disorder, GI bleeding within 10 days, cerebrovascular accident within 6 months, intracranial or spinal surgery within 3 months, head injury within 3 months, and the relative contraindications are major surgery or trauma within 10 days, hypertension more than systolic 180 and diastolic 110, cardiopulmonary resuscitation within last 10 days, puncture of a non-compressible vessel, intracranial lesion, pregnancy, diabetic hemorrhagic retinopathy, retinal recent eye surgery, liver failure, and bacterial endocarditis are contraindications for a pharmacological thrombolysis. So Altiplase is the usual thrombolytic agent we use. Recombinant tissue plasminogen activator. There are two regimes we follow, either a low dose, which is 1 milligram bolus followed by 1 milligram per hour infusion for a 10 to 12 hours, and then followed by we'll do a check angiogram, and then depending upon the findings of check angiogram we proceed, and we usually administer 300 to 500 units of heparin through the sheath to prevent a sheath thrombosis. And there is a high dose regimen, 10 milligram Actilis given as a bolus over 5 minutes, followed by 0.05 milligram per kilogram per hour infusion of Actilis. Maximum we can give 4 milligram per hour, and we continue this for 6 hours, and we do a check angiogram, and then we proceed according to the findings. So fountain infusion catheter, 4 French catheter with a working length of around 90 to 135 centimeter, infusion length of 5 to 550 centimeter. So we wedge the multi-hole area in the thrombus, and we do a thrombolysis through the catheter. So the distal side hole marker placed at the end of the thrombus, proximal side hole located just proximal to the thrombus origin. And we have to monitor the serum fibrinogen level. If it is drops less than 100 milligram per deciliter, we have to stop the infusion. There are few studies which compared thrombolysis, ROCKET study, or these are randomized controlled study done to see the urokinase versus embolectomy. So 1 year amputation free survival more with the thrombolysis group may be due to more death in the surgical group. So the comorbidities and the mortality rate was high in the amputation in the surgical group. So the 1 year amputation free survival they have noted more in the thrombolysis group. Maybe because of the high death rate in the surgical group. Style trial, patients with a short duration of symptoms, better outcome in thrombolysis group. So patients comes with less than 2 weeks of symptoms. So those patients who underwent thrombolysis had a better outcome than more than 2 weeks of symptoms. So more than when the patient presents with more than 2 weeks of symptom, surgical group had a better outcome. TOPAS trial, they didn't find not much difference in outcome and amputation free survival in between thrombolysis and surgical group. So these are the trials done to compare the efficacy and long-term outcome comparing thrombolysis versus embolectomy. The complications of thrombolysis are hemorrhagic complications, intracranial hemorrhage, and it is more with the therapeutic. When they have noticed that in spite of giving 300 to 500 unit of heparin through the sheath, if you are giving therapeutic dosage of heparin along with the actylase, then the rate of intracranial hemorrhage was high. And the other complications are compartment syndrome, distal embolization, access site hematoma pseudo. So when a patient undergoing thrombolysis, the thrombus particle, the fragmented particle can go distal embolization and it can occlude the outflow vessels. And blind puncture or multiple punctures at the access site can produce a hematoma or pseudoaneurysm. So the other is pharmacomechanical thrombectomy. So devices are intended to be used in conjunction with the thrombolytic agents, accelerate the speed of thrombolysis. So that will speed up the acceleration of thrombolysis and we can reduce the dosage of the thrombolytic agent. So the techniques are ultrasound energy, echosonic endovascular system, power pulse injection angiojet, mechanical mixing trellis catheter. So these are the technique. Either we can use an ultrasound energy to increase the penetration of the thrombolytic agent into the thrombus. Either it could be ultrasound energy, it can be a power pulse injection, or it can be a mechanical mixing. And it reduces the dose of the lytic agent and decreases the bleeding complication. So trellis is a trellis peripheral infusion system. 5 separate entry port when inflated. The balloons are designed to isolate the treatment zone to keep the thrombolytic agent locally at the infused concentration. It's an 8-French coaxial system or runs on O35 guide wire. Balloons are also help to prevent the downstream or upstream release of the embolic debris. And after balloon isolation of the treatment zone, thrombolytic agent infused through a separate proximal infusion port. In echosonic endovascular system, ultrasound is used to facilitate the clot penetration by a lytic agent. 5.2 French multiple lumen drug delivery catheter and a coaxial ultrasound core wire we use. Active length of catheter is 6 to 50 centimeter and the transducer is a 2.2 megahertz to is a frequency 0.45 watts spaced approximately 1 centimeter apart. Back end of the catheter has a 2 additional port, one for infusion of the lytic agent and the other for the infusion of the normal saline as a coolant. And the thrombus is exposed to ultrasound. So studies shows that the thrombus which is exposed to the ultrasound absorbs 48% more tissue plasminogen activator in 1 hour and 84% more in 2 hours and 89% more in 4 hours. So when the thrombus is exposed to ultrasound, so the absorption rate of the thrombus, absorption rate of the thrombolytic agent is high. The next is angiojet thrombectomy system. Is a power pulse spray mode. Tissue plasminogen activator is actively injected into the thrombus, allowed to dwell there for a short time, 5 to 20 minutes, and aspirated. And the components of the system is catheter. There is a pump set and a drive unit. Pump set and drive unit generate a high velocity saline jet at 350 to 450 km per hour. And the thrombus surrounding the catheter trip is fragmented and rapidly evacuated through the effluent lumen in an isovolumic manner. So there are some specific complications like hemolysis, distal embolization, bradyarrhythmias, and renal failure can occur in a patient when they are undergoing angiojet. So this is roughly regarding the angiojet system. Percutaneous mechanical thrombectomy without thrombolysis. So some patients who are contraindicated for a thrombolysis. So thrombolytic agent using altiplase, there we can go for a mechanical thrombolysis without using any thrombolytic agent. So the classified as a hydrodynamic use of a stream of fluid and hydrodynamic forces to extract the thrombotic material from the lumen, like again in the angiojet where without using a actylase. Rotational bar mechanical, which is not much used in clinical practice because this rotational device produces a lot of intimal injury, so that it is of not much use. And the other is an aspiration thrombectomy catheter. So it's a rotational device because the device produces a lot of intimal injury we are not used nowadays. So what are the advantages of the percutaneous devices? It creates a channel in a occluded segment. So by time for a complete thrombus removal, temporary channel provide adequate blood supply for the survival of the ischemic part of the body, and it reduces the thrombus load and thrombolytic dose. Less chance of hemorrhage complication, and the sole mode of intervention when thrombolytics are contraindicated. So there is a paper published by Kashirajan compared angiojet with a conventional methods, and there were no difference in major amputation, but less mortality and systemic complication in angiojet group. So they have noticed there is a less mortality and systemic complication in angiojet group, maybe because they were using less amount of thrombolytic agent. So what are the complications of endovascular options? One is again distal embolization. Incomplete removal of thrombus with a mechanical thromboaspiration can be other complication. Intimal injury with a large diameter devices and damage to RBC, it can produce hemoglobinemia, hemoglobinuria, and renal failure. So now we come to surgical intervention. What are the options? We can have balloon catheter embolectomy, bypass procedure to direct blood flow beyond the occlusion, endarterectomy with or without a patch angioplasty, and the other is a hybrid procedure combining open and endovascular techniques. So in 1963, Fogarty had to destroy embolectomy catheter for the removal of the clot via groin. So we can see different size of the embolectomy catheters and we use for embolectomy. Balloon catheter thrombectomy or embolectomy artery. So we all know how you do expose the vessel. So in case of lower limb embolectomy or iliac embolectomy, so we expose the groin and we take control over the common femoral profunda and SFA and other minor branches. Then we do an arteries exposed. Longitudinal transverse arteriotomy is done depending upon the need of the endarterectomy and plasty. Completion angiogram. So we retrieve the thrombus with the embolectomy catheter. We do a completion angiogram and after embolectomy. And sometimes if we are difficulty in finding negotiating the catheter across the lesion, then we can use over the wire embolectomy catheter to direct the embolectomy catheter into the tibial branches. So this is regarding in general about the surgical options. So if we can get away with a simple embolectomy, then it is well and good. Sometimes we may come across chronic component when we do an embolectomy. So we have to proceed with the hybrid thing. So we have to remove the acute thrombus, then we do balloon angioplasty for the chronic component. Then sometimes we may have to proceed with the stenting. That's called hybrid procedure. And sometimes when we expose the artery, we may have to do an endarterectomy of the common femoral artery. Then followed by we have to do a distal embolectomy, and then we have to either close with a simple primary closure or a patch plasty if you anticipate any stenosis of the endarterectomy site. And sometimes we may have to proceed with the bypass procedure also. Few words regarding upper limb ischemia. Age often older age group compared to the limb ischemia in a lower limb, and it usually patient presents with a category 2A limb ischemia, seldom threatens the limb. Main reason for intervention is to prevent a future exercise related fatigue. So as I already mentioned, young patients and all, when they present, even though they are presenting with the category 1 or 2A symptoms, it is better to proceed with the complete revascularization of the limb, because in future, if you leave the lesion and if you trust on the collateralization, future the patient can present with a claudication kind of symptoms. Most common causes are cardiac embolism, and sometimes we have seen patient can have a thoracic outlet syndrome with a subclavian artery aneurysm. Patient can present with a dislodging thrombus from the aneurysm. So always when a patient presents with upper limb ischemia, we have to roll out the arterial or thoracic outlet syndrome, especially arterial, and is there any subclavian artery aneurysm? And diagnosed with the Doppler mostly or CT angiography suggests to rule out the suspected subclavian aneurysm, TOPAS, and arch of aorta disease. Managed initially with anticoagulation first, and 50% of cases improve with the anticoagulation alone. Critical category 2B with the threatened limb, urgent embolectomy was advised. And the complications we can see post revascularization are myoglobinemia, hemoglobinuria. Okay, when the large volume or contrast used, procedure time exceeding 10 times, or infusion volume more than 300 ml. So the patient can present hemoglobinuria and myoglobinuria. And the patient, if they have these symptoms, the patient managed with a good hydration alkalinization and forced diuresis to keep the urine output more than 100 ml per hour. And the other complication is a compartment syndrome. So post revascularization, either we will see on table patient the compartment getting tensed up, or sometimes we may have an anticipatorily that the patient can go for a compartment syndrome. So we may have to proceed with the fasciotomy. To relieve the compartment pressure, anticipatory fasciotomy in impending compartment syndrome is advised. Thanks. Thank you, sir.